Dr. Michael Saag, Professor Emeritus of Medicine, Microbiology, and Public Health at the University of Alabama, Birmingham, who really needs no introduction, will lead this interactive ART case series. And we've invited five of our speakers up, six, to interact on these cases.
Thank you, Elaine. Thanks. It's really good to be back with you guys. I've got new cases, same old problems. And so we'll crash through these. And it's like everything else. The questions remain the same and the answers change. So we'll go through what's new and some interesting things today. We have a couple new panelists, Dr. Ole Hendrik, who is from Boston. You're going to be hearing from him later today on gender-affirming care, and Dr. Melanie Thompson, who I think a lot of you know from Age Resource Consortium in Atlanta, ARCA, and has been involved in HIV clinical trials for 3+ decades, and is going to be talking to us later today on primary care. So we have a wonderful panel, and I'll go ahead and get started. I don't have any relevant financial relationships, and we're going to go through a wide array of not just antiretroviral therapy and complications, but also some new stuff regarding new diseases and some controversial areas, some of which will pick up on what Roger just reviewed and so forth. So as you know, to make it simpler, I sort of bring out the main point at the beginning. What's the question medically we're at? Otherwise you get lost in the details of the case. And so this one's just about what should I use for initial therapy. This is a guy who's been coming to this conference, I think now for 10 years. He used to be 38, now he's 48. He's got same viral load, same CD4 count. Other labs are normal. You have a genotype that's wild type, pretty healthy. Otherwise, he's okay to start therapy. So which regimen would you choose? And you have a list here. This is initial out-of-the-gate therapy. Let's go ahead and vote. That's from hair. Yeah, I think so. Like a modern version of hair, ripped open by metal. No, it's not. Never mind. All right, let's see what we got here. It sounded like hair to me. Okay, so, I didn't introduce Dr. Alopre, who's going to be with us later today. And I'm going to start with you, Letitia. She's a colleague of mine at UAB, and is going to be talking to us about all kinds of STI and PrEP. Yeah. Okay, so give us your view. What do you do in the clinic in Birmingham? Move closer to the mic.
I'm moving closer. So I think I agree with the audience. There's actually a study that was presented at CROI, the laptop study, that showed that in patients with advanced HIV, this would be a good regimen to start. They would have appropriate response. So I think that always true in blue, I tell people it's a great medication to prescribe.
Yeah, it's what most people do these days. Anybody want to comment on going direct to inject? I mean, literally with no lead-in, with a viral load of 280,000. Dr. Landovitz, any thoughts?
Yeah, I think, that in terms of long-acting injectable therapy, I think that's the holy grail. We would love to be able to do that, particularly for people that we know might have challenges or have predictors of having challenges to adherence to a daily oral regimen. I don't think we're there yet. There's cohort-level data suggesting you can do this if people do not have resistance to either of the agents involved, which sometimes is a tricky thing to evaluate. You did tell us in this case that the person had wild-type virus, but we do not have randomized data yet. There is a study that is about to go into the field that's sponsored by ViiV called the CROWN study. Well, it's actually in the field called the CROWN study that's actually interrogating this specific question in a randomized fashion. And there are data both from the CARES study done in Africa and the latitude study done by the ACTG, where people who were supposed to be suppressed, but not everybody actually was suppressed, who were enrolled in this and seemed to do okay. So with wild-type virus, it might be okay, but I don't think it's ready for prime time yet.
Not yet. And any comments, anyone, on starting right away with dolutegravir 3TC? Now, the artificial nature of this question, meaning I made it up, is that you have the wild-type genotype at the time you're seeing the patient. You don't have that usually. But let's say you did have it. Could you start with dolutegravir 3TC? There's no M184V. The viral load's 280,000, lower CD4 count. We don't have much data in that space. Anybody comfortable with that? Roger?
Yeah, I think that the concerns for dolutegravir 3TC had been, number one, in the trials, high viral loads were excluded, and even if some snuck in, and then low CD4 count as well. So those are the two concerns. And the third one being it doesn't contain two Hep B active drugs. So in context of starting antiretroviral therapy when you haven't excluded Hep B yet, that has been a concern. The newer data suggests that it actually has been shown to work in people with high viral load, and lately, I believe 3 or 4 months ago, a study showing that there was efficacy in people, equal efficacy in people with CD4 counts of less than 200. So confidence will grow in that regimen, although we have to stay consistent with the guidelines thus far, even if we are HIV providers and we're mavericks. And so that's...
Right, so I think maybe a happy way forward for those who want to use the 2-drug regimen, start off with the 3 to start, get the viral load suppressed and switch over. There's usually not a problem. The answer D, the cabotegravir right off the bat, is a little bit of a curveball from last year. Those of you who weren't here, there was a case that I presented of someone who had exhausted most options, for whatever reason, wasn't taking medicines regularly. Viral load might have been this high with the low CD4. And the newer data that had just come out then was just going right to cabotegravir and rilpivirine and just taking a flyer because the patient wouldn't take enough medicine to get the viral load down to meet what the approval was. And remarkably, at least in the early studies out of San Francisco and a few elsewhere, that tended to work in a good proportion of people, despite the fact that there even was some resistance, not so much to the 2 drugs, but other resistance. And so I think that's the setting where you will use this. I think a lot of you have already been doing that. More data at CROI this year, smaller studies, but kind of amplifying that theme. So somebody hard to treat because they're having trouble with adherence, you can go to that if you've run out of other options and you can't have success with oral therapy. A lot of this has been covered. Raj Gandhi was the lead author on the new guidelines that came out in December. We're going to refer back to those. Dr. Landovitz was a part of this, especially for the PrEP indications. And this is one of a series going back to 1996. So it's every 2 years, and there's a lot of more information in this on PrEP this year. So how do I manage weight gain due to ARV therapy? And we have an endocrinologist with us. We may turn to him. 47-year-old woman started Victaf FTC 12 months ago. Reasonable viral load in CD4, had a great response. Since starting her regimen a year ago, she's gained a pretty good amount of weight. Her BMI has gone up to 32. Her fasting glucose is just at the pre-diabetic range, and her A1C is similarly. And besides diet and exercise, you recommend which of the following? I'll let you read through those, and then we'll turn to Ole for commentary. Let's vote. Somehow this fits my personality. I'm not sure why. Okay. Okay. Ole, take it away. Give us a...
Yeah,
an endocrinologist perspective of this pre-diabetic person who has gained some weight.
Yeah, so this is where I actually can contribute something in this conversation. So as a non-HIV provider, of course, I see a lot of patients with weight gain for any reason, and my first step is to go and look at the medication list and look for causative medications and see if we can make a change or a switch. So I would sort of firstly go back to the prescriber of the medication and just ask, are there options for this patient to control their HIV that is not going to be associated with quite as much weight gain? But very often that is not the case. We do, of course, evaluate for other secondary causes also, but mostly the secondary cause is 2025 with easy access to food and poor access to exercise and physical activity. And that is a secondary cause that I can't solve. So pretty quickly, I would probably move on to discussing with this patient how we can help them avoid further weight gain and ideally also lose some weight. And I know we think about lifestyle interventions first, and I think it is important to have that conversation. I also will say that when you look at lifestyle interventions delivered in the time frame that most of us have available, so meaning we're not here talking diabetes prevention program where you meet for hours every week, we're talking about 5 minutes at the end of a visit, they don't work very well. So I have my 2 or 3 things that I talk to patients about. I say, why don't you track your weight, track your exercise, track your caloric intake, and then come back to me in a few weeks and we'll see, or in a month or 2 if I can, and we'll see if you've made any progress. Typically, not much progress. Some patients are really embracing it, but most people have difficulty with losing weight through just lifestyle interventions. So I tend to then move pretty swiftly to medications that are approved for weight loss, assuming that I can get it covered by insurance. And I hear the audience nodding here. In Massachusetts, I'm lucky in that even our Mass Health, our Medicaid covers weight loss medications. So I actually mostly am able to get the newer weight loss medications approved. And so I would pretty quickly go to semaglutide or to tirzepatide. That is, if the patient is, of course, interested in that approach. I would not do semaglutide 1 milligram weekly, though that dose will have the patient call you vomiting. You start at a low dose and work your way up. But otherwise, I think that's a pretty reasonable way to go. If you can't get that approved, or if the patient doesn't want to do medications, I think metformin doesn't want to do injections. I think metformin is a fine choice. People lose a few pounds on it. It might help a little bit with this pre-diabetes that the patient has. Again, we know that from the diabetes prevention program that second to lifestyle, metformin was the second best option to avoid progression to diabetes. Things like phentermine might be other options also. And then as a non-HIV specialist, every time I prescribe any medication to these patients, I go and look up interactions because I never know exactly what it is that you guys do.
So thanks, that's real helpful. The reason I showed this is because it's a common question. I think we've all been convinced now that changing the regimen doesn't work. Going to a different ARV regimen. There's a study in ACTG that's somewhere along with doravirine and dolutegravir. Is that no, doravirine and...
You're switching off TAF and off bictegravir to either doravirine, TDF, or both.
Right. So we'll learn more, but we'll see what this shows. And I know it's just gone to Data Safety Monitoring Board and maybe it's coming out soon, but until then, data to date don't show that changing the regimen works. In my experience, despite whatever counseling we do, diet and exercise only goes so far. Metformin isn't a bad choice in this case, and it's easy to get it approved. And in a practical way, you may start applying for the semaglutide because you know it's going to take months and work on these other things. And if it comes through, great. And if it doesn't, you're already working on it. So metformin's not a bad choice. Bariatric surgery I threw in here just because that is an option for people that have BMIs over 45 or 50, and sometimes that's done. But I think most often, correct me if I'm wrong, Ole, but that is used after some weight loss approach that hadn't worked.
Right, you need to have sort of failed other approaches, and I'll say nowadays we do much more medications if we can get it approved, just because especially tirzepatide is almost as efficacious in terms of weight loss compared to bariatric surgery.
Yeah,
and
so maybe
others.
that's on the way out,
Yeah.
right, okay. All right, something completely different. What about Delta virus, hepatitis D? Y'all ever heard any pharmaceutical reps talking to you about that? Yeah, maybe a little bit? Okay, so let's dig in a little bit. This is a 48-year-old guy, the same one as before, just copied and pasted it on my slide here. Except this time he started on dolutegravir TAF FTC. His other labs was normal. It was hepatitis surface antigen positive, surface antibody negative, and E antigen negative. The question is, would you test for HDV virus? Go ahead and vote. And you could say, you could answer it one of two ways, hypothetically, or what do you really do? I'd prefer the latter. Juana goes to Jamaica. Something like that. I can't figure this one out.
La La Land. Pasek and Paul.
Oh, okay.
Musical
So
adjacent.
we're dancing down the Los Angeles freeway. Okay, got it.
Traffic.
In traffic, yes. Okay, so the plurality sort of checks for this. Anybody on the panel do this regularly? Anybody want to defend it?
I think the guidelines say we should in S antigen positive people, but I have to admit I haven't been.
Yeah. Doctors up.
We were talking on this end that we do it because the guidelines say we should do it. But then again, there isn't a lot that we can do with that result other than explain to patients the positivity.
Right.
So it's sort of a test we've done because it's recommended, but
Yeah. So the,
Well, and the hope that maybe a drug would indeed work at some point, which really so far hasn't emerged.
so there's an epidemiologic reason to do it, right? Because there are decent data that show roughly, pick a number, 10% of patients with HIV who are antigenemic will be also positive for Delta. And we all learned about Delta in training when there might have been that rare case who showed up with a new infection and had fulminant liver failure. That's different. This is someone who's been carrying it for a while, and you can test with antibody and or a PCR for the virus. And there are data that show that people with co-infection with Delta and B have faster progression to cirrhosis. And so that's a reason to be thinking about it. But to Jason's point, what should I do, right? The only drug that's available is this bulevirtide, and would you go ahead and treat with that? And there's some issues here that, go ahead and vote.
September 1st, 1989. Dear Diary.
Heathers, the musical, coming to Broadway soon.
Boom! Yes!
they've taken your suggestion to heart.
We're in a Broadway theater, or close to Broadway, sort of just a few
These
blocks.
kids that I've known all my life, and I ask myself, what happened?
Listen to the London cast recording, Carrie Hope Flesher. Amazing.
Yes,
We were so
I love
tiny,
this.
happy and
Okay.
shiny.
Ah, nice answer. Yeah, we're taught to say, I don't know. And the answer probably is not sure. The issue here is that that drug exists. It's an injectable given daily, right? It's approved in Europe for this indication. It is not approved in the United States. So you can't really get it. So I just put this in here to raise awareness because it is an emerging thing. Maybe if I'm back next year, we can have some more to talk about, but just something to clutter your brain with, and now you can clear that out and move on and do whatever you're going to do. Okay. Can I start a long-acting ARV in someone who's got HBV? Last year we talked about isolated core. I've got some follow-up information in this case. So it's the same guy, spare you having to read things. Genotype was, now he's doing well, and he's got an HIV RNA of less than 20 and a CD4 count of 270, just cruising right along. and he wants to go to cabotegravir rilpivirine, and you dutifully order a hepatitis B series. And which of the following are a pretty good indication that you should not, the one answer that you should not move on, or you should not move on at all? Answer E. Go ahead and vote. And
Hello, my name is Elder Price, and I would like to share
Everybody
with
knows
you
this,
the
right?
most amazing book.
ding dong.
Hello, my name is Elder Grant. It's a book about America a long, long time ago. It has so
I
many
like this
awesome
song. I may
parts,
just listen
you
for a
simply
while.
won't believe
But
how
I'll go
much
ahead and
this
move
book
on.
can change.
Okay. Wow, good. 68%, at least in my mind, nailed the answer. Anybody want to jump on this and talk about it some? Jason, Melanie, and, no?
Well, you know, I think we are beginning to see these cases arise when we change people to two-drug therapy or long-acting therapy, which right now, none of which contains any hepatitis B suppressive drugs. You know, in my mind, it just raises the issue that we need to be screening people for hepatitis B, and we also need to be vaccinating people for hepatitis B, because sometimes in the rush of getting people entered in clinic, we don't always do the basic things that we need to do. So I would say, you know, I would in general agree with this.
Right. So these are data from a VA cohort, not from Southwestern, I don't think, in Dallas. But it's the VA, the VAX, which is a cohort. And the things to focus on are these. If someone's never been antigen positive and has always been antibody positive, right, but they have a core antibody which tells you it's not just vaccination, they have a very low chance of a flare. Conversely, someone who is HBV antigen positive and antibody negative, like this case, they can have about a 10 to 12% risk of a flare. Now you may say, do they die from that? Probably not. But the flare is something that we tend to want to avoid. It means you come off an tenofovir-based regimen, which is sort of keeping the HBV under control. You pull that away, and then it's only 10%. It's not like everybody. It's enough to get a black box warning. But these are data that are beginning to emerge. Last year we talked about core antibody. I'll give you an update. I've been talking to a lot of, so that was a case similar, exact case actually, except I gave you that it was core antibody positive, but everything else was negative, including surface antibody. And so he's obviously had the infection, but did not mount much of an immune response with antibody, surface antibody. And last year we sort of said, no, I wouldn't treat him. What the hepatologists that I'm talking to over the last year have said, vaccinate him. You know, give him the HepaSlav, which Melanie's going to talk about later. Give him a 3, full course of that, and the 98% chance that antibody will be produced. So that's kind of the way forward. You get the antibody, then you might be able to move on. So just wanted to bring back what we had talked about last year a little bit. For
Mike,
those.
the one point also is, right, you can safely put people on a non-HPV suppressive regimen. You just need to then add in entecavir,
You could do
right?
that.
You could do that, but of course the point of then giving them the injectables goes out the window, because then they have to take a daily pill anyway.
Right, that's kind of, yes, right. So this, we have some experts on the panel. What should I use as initial therapy in the setting of PrEP failure? So this is a story about a 28-year-old guy, shows up with HIV, newly diagnosed, but he had been on CAB 2Q months for PrEP and has not missed a dose. He's gotten it every time. That's an important point. And his HIV antigen, HIV was detected by antigen antibody test. You finally get a CD4 count and viral load, and the viral load's kind of lowish, maybe hard to get a genotype. Other labs are normal. Medical history otherwise negative. Normal renal function, wants to start therapy. which of these regimens would you lean towards using? Go ahead and vote. CAB alone. That's the Howard Johnson kindergarten class singing down the road here. Yeah, they're eating ice cream and singing and having a good time. 64 flavors on that. Does anybody know what that is? Good. We're in good company. All right. So interesting. Most people went with a boosted PI. Some felt good about going with BIC. Letitia, you got any thoughts here? What would you do?
I never leaned forward enough. Yeah, I think that right now guidelines recommend that you do a boosted PI regimen. I think the question is, which I know we don't have the antigen antibody, but should we still be checking RNAs? And whether this is actually a true positive. So yeah, I think right now I would do that, and then I would continue to follow this patient and get antigen antibody testing and see if they actually seroconvert.
Yeah, so they have the antigen antibody test was positive, and an RNA is like 280.
Oh, was it positive?
Yeah.
Okay,
Sorry.
okay, all right.
That's okay. So now, does that change what you say, or do you think they're truly infected?
If the antigen antibody came back positive, then yes.
Yeah, and then the RNA was low but positive.
Yeah, I think Rafi has the knowledge based on RNA testing and at what threshold typically you'd see somebody actually have a true positive. But yeah, with the antigen antibody being positive,
Right.
100%.
Rafi, commentary on why it matters maybe that he was fully adherent versus intermittently adherent, and what would you do in this setting?
Yeah, I completely agree with Letitia. The data from HPTN 083, which was one of the 2 registrational trials that supported the regulatory approvals for cabotegravir, showed that the context in which you get integrase resistance is not during the tail, like after you stop it or if somebody's super late in getting their injection, as we had feared during the clinical trials when we were all crazy about, you got to cover the tail, cover the tail, cover the tail. It's actually when people, which is a rare event, break through cabotegravir prep with on-time injections. So this is exactly the clinical context in which you worry about integrase resistance. Now, if even at a viral load of 280, you can get a genotype and exonerate the presence of integrase resistance, then probably a bictegravir or dolutegravir containing regimen is fine. But absent the ability to do that, I think the smart thing to do would be to start with a boosted PI-based regimen. Again, that's assuming you can't get a genotype, because some people say, well, can't you use an NNRTI in that case? And again, if you can't get a genotype, depends what you think the background rate of transmitted NNRTI resistance is in your population. But start with a boosted PI. Obviously, we'd prefer not to have people on boosted PIs because of drug interactions and tolerability. When they get to undetectable, probably it's fine to switch them to an integrase-containing regimen. So that's probably how I would approach it, get them to undetectable. It's not going to take much with a viral load of 280, and then switch after that.
Yes, I may have missed this, but someone who has been getting it on time, the regimen cabotegravir alone fails, what's the proportion of integrase resistance to cabotegravir in that setting?
100%.
See, I think that was the point I was trying to get at. I feel like one of those attorneys, that you know the answer to the question before you ask, and then, aha, jury, yeah. So that's why you might want to start with the boosted. And it does matter a bit as far as the relative prevalence of cabotegravir resistance, that they've been taking it regularly or missing doses. It's kind of a subtle but important point. All right, Tisha, I'll go to Jason first because he's the STI. You're both STI. A lot of STI expertise here. Bacterial vaginosis. So a cisgender woman is followed by you who's monogamous with her husband, diagnosed 10 years ago with HIV. And she's on Big TAF FTC and doing nice, but she has recurrent bacterial vaginosis and has been treated multiple times and, comes back every 4 to 6 months or so. And her other STI screening is negative. And so now the question is, what are you going to do? So you have a couple oral regimens here with tinidazole and metronidazole. You have gels, and then you have this other option of giving her one of the orals and treat her male partner. What would you do? Go ahead and vote.
If you say, come with me off to Massachusetts, then to Massachusetts we will go. We will buy dishes there, maybe even 2 sets. Buy the finest china, then we'll dine a while on crepe Suzette's.
I think they just think I'm a child, which is sort of true, because this music has a theme. Let's see what the audience said. All right, 85%. I have nothing to teach. Jason, you want to go?
Clearly, the audience saw the recent publication demonstrating reduced recurrence rates if you treat the male partner. And so I think that's obviously a great place to start. Obviously, this is something we've been struggling with for years, how to deal with recurrent BV. It seems that treating the male partner certainly makes a difference, and so I think that's the great starting point, and starting with an oral regimen, treating both people.
So Jason, what do you think about the acceptability of these male partners with penile BID schemes?
Yeah, I think it depends on if they're a primary partner or not a primary partner. I think for people who are primary partners, we do
Tertiary partners.
Huh?
Tertiary partners.
I think with tertiary partners, just like with any STI, it's going to be much more challenging. We struggle with all of them. I think this will be no different, but we should continue to do the best that we can. Things like expedited partner therapy, if that were allowed for BV, might be beneficial. It's not currently, but maybe that's something in the future based on this type of study. But just finding ways to engage those people in care, not just for BV, but also for other STIs and treatment. And so any excuse we have to bring them into care, get them tested both and treated for both BV and other things, I think is valuable. So we'll try.
I'll just add, this is really exciting. I'll say at UAB, there's been several proponents of the fact that this is a sexually transmitted infection for decades. Dr. Jane Schwepke, Christina Musney, so they were very excited that this data came out. So yeah, we all celebrate it. We'll be giving metronidazole to everybody.
So what Letitia is referring to is that at our place for decades, the STI folks at our place have been saying it's an that bacterial vaginosis is an STI. Why are we not treating? And the guidelines, even if you look at them today, because this study was just released in March, a great editorial by Christina Musney in New England Journal with this paper. But the guidelines today say don't treat the male partner, and that's probably wrong. So it gives me a chance to say one of my favorite lines is that how, those of us with gray hair have been doing this for a while, we see things change in the field of medicine, things that you're never supposed to do, suddenly you can do, or you're supposed to, like beta blockers for heart failure. Who knew, right? Back in the 80s, we never did that, and now we always do it. And so it gives my line of, there's a thin line difference between what's dogma and what's dog manure. So if we can just remember that things change, and it's my favorite line on rounds, besides Hibgia. Okay, that means had it before, got it again. Most common diagnosis known to man. Okay, now, this is really coming right, slow ball, not even a fastball, down the middle to the end of the table. 30-year-old guy presents with new lesions on his buttocks, groin, back, and face. He's sexually active. He's MSM. Reports fever, anorexia, asthenia, failure to thrive. Pretty sick. Has a viral load. HIV has been off his therapy for a while. Some recent sexual contact. Has been UDS is positive for methamphetamine and requires hospitalization. The onset of symptoms was 8 days ago. That sound familiar? And so now what do you do? What do you do? Go ahead and vote. Culture is ultimately positive for mpox. I'll give you a hint. This isn't from Sweeney Todd, but it could be. Another movie for kids. Okay, all right. 62% has Tecovirimat, and maybe that's because, I don't know if there's anything else you can use. So, Jason, what are you going to do? Somebody comes into your clinic and you're seeing them, you're going to admit them. What are you going to tell the house staff to do when the patient gets to the floor, besides fluids?
Yeah, I have an epic message right now that's actually a lot, Brett's nodding. We have an epic message right now a lot like this case. So this is challenging. Obviously, we haven't said the diagnosis, but it's clinically consistent with Mpox. The lesions are consistent with Mpox, the story is. And so we're all talking about treatments for Mpox. The first thing is also to just test for other sexually transmitted infections, because co-infections are present in about 40% of people, and we've certainly been fooled before with HSV, syphilis, and other things looking similar. But this is a fairly classic presentation, especially with the fever, the syndrome, and the prodromal symptoms as well. What was the CD4 count again? I'm sorry, I missed it. 280? Okay.
Something like that.
And a higher viral load?
In a high, well,
Yeah.
28,000.
Okay. So, one of the worries, obviously, is people who are immunocompromised can have much worse outcomes with Mpox. In fact, most of the people in the United States who've had significant morbidity or mortality have been people who've been immunocompromised, most commonly with advanced HIV. And so that sort of leans in our direction of wanting to try and do something. For those who were at CROI, we presented the analysis of the STOMP trial. The trial was actually stopped early for futility, as there was no clinical benefit seen from treatment with Tecovirimat. There was no faster time to clinical resolution, and there was no decrease in time to pain improvement. And so we really didn't see any outcome or any signs of improvement with Tecovirimat, which would really lead me away from recommending monotherapy with Tecovirimat. It's a little bit too late for vaccination. Really, the only options at that point would be supportive care or combination therapy.
Which combo?
Yeah, and for that, it would really depend on how sick the patient is. If it's somebody who's being admitted with a sepsis-like picture concerning for disseminated Mpox, I probably would think about combination therapy with Tecovirimat and brincidofovir. They're both available through separate INDs, which makes the process fun and exciting. But there is good animal data. Again, we don't have any human data, but animal data about true synergy between these two medications. And so for a patient who looked like they were critically ill with disseminated disease in multiple organs, I would think about combination therapy, keeping in mind that there is no evidence base for that and it may not work, but there's animal or non-human primate data for that. And so that's the best I could do. For people who are coming in just for pain control and other things at this point, it's really supportive care only.
So your house staff hate you because you make them fill out all those forms for the compassionate use, right?
We may do a lot of it ourselves. I'm looking at the person.
Smart
There's a person in the
man.
audience who actually does most of it.
Smart, yeah.
Yeah, so I would just add that I think it's really important to get this person back on their HIV medication, because the CD4 count may be 280 today, but it is headed down, and probably fast. So I think one of the most important things to do is to really get the person back on their medication.
So here's a question. Brincidofovir, for those who aren't familiar, is a prodrug orally bioavailable for cidofovir. Doesn't get to high enough levels. But we do have access to IV cidofovir, may have to have, but it's an approved medicine, right? What about if somebody's really sick and you use the probenecid prep, why not use that here? Besides, there's no data, but I mean.
So we have used cidofovir before, especially early on when it was harder to get brincidofovir, or it's going to take a long time. So there's no reason you can't. In fact, actually, the non-human primate models use cidofovir because they miss whatever enzyme converts brincidofovir to cidofovir. So the non-human primate models actually use that. The concern is obviously the renal toxicity.
Yeah.
Brincidofovir is a lot more tolerable than cidofovir, but in cases where we didn't have time to wait or didn't think we could get it for whatever reason, we have tried it.
So again, those of us with a little gray hair remember using cidofovir quite a bit for CMV and acyclovir-resistant herpes on occasion. The trick is, the way to avoid the renal toxicity or minimize it is to make sure that they get the pre-dose with probenecid. If you don't do that, you do a lot of damage. But you got to be really vigilant about using probenecid, and we had incredible nurses in our outpatient setting. I think, Roger, you were there around that time, and they watched it like a hawk. And we didn't, knock on wood, have many renal complications with cidofovir, but you got to be on top of it. So just something, last year this answer would have been easily, 99% would have been saying Tecovirimat, and now that's been stomped out, so to speak. Couldn't resist. Okay, how do I manage heart failure? 41-year-old guy, progressive dyspnea on exertion, but no P&D, but does have 2-pill orthopnea, has a history of meth use, diagnosed 15 years ago for HIV, persistently undetectable on dolutegravir 3-TC, a pretty reasonably high CD4 count. Exam shows slightly elevated JVD, a soft S3 and trace edema. Renal and liver labs are normal. He's on amlodipine, former smoker, and the electrocardiogram shows an ejection fraction of 35 to 40% with symmetric wall motion. So this will age, whoever's older will answer A, but DIG, Lasix, beta blocker, Entresto, the SGL2, one of those inhibitors, or refer to refer to cardiology and punt. Go ahead and vote.
Alabama doesn't punt. Alabama doesn't punt.
That's right. There's very few punts. This is one of those, you might use more than one, right? But pick the one you think is the anchor drug. What do you think is really the most important?
Roger, Mufasa dies.
Spoiler alert. Oh my God.
Oh my God, did some of you not see The Lion King? You didn't know Mufasa died? I'm sorry.
You're terrible.
All right. Poor Digoxin. I knew him well. It's like Hamlet, you know. Alas, poor Digoxin. I knew it well. Comments from the, maybe Melanie, you're staunch, long-time primary care doc. You've seen this before, and what have you done?
Well, I have to
To
say
the
that
microphone
I
a little
think our
closer.
awareness of heart failure is actually increasing, and there were data presented at CROI about really the increased prevalence of heart failure in people with HIV, so we need to be looking for that. You know, I think that the SGL2 inhibitors, as well as beta blockers, mineralocorticoids probably rather than Lasix. It sounds like he needs a little bit of diuresis. And, you know, I don't think referring to cardiology is necessarily a punt. I think, you know, the person probably needs some additional workup. So I wouldn't view it as a punt. But you know, I think this is a situation where it's going to be combination therapy with 3 or 4 drugs.
I couldn't agree more. It is not a punt. It's a handoff. And hopefully you don't fumble. So I raise this because I thought this was really important at CROI, and for those of you who didn't go, or those of you who went and missed it, Matt Feinstein from Northwestern gave a wonderful overview. And the take-home point for all of us is that the people we're all following with HIV are having more experience with heart failure. And you're seeing it, I'm sure. And this slide just basically says it's complicated. All right, you don't have to, if you can get the slides later, you can read the details. Really fabulous talk. But the risk is about 2-fold higher for people with HIV than age-matched controls. This is from the Scenic study, but what's cool about that group is that they adjudicate the endpoint. So it's not just coming from a medical record, which we know can be wrong. And in fact, they screened 9,500 people, found 402 with possible heart failure, and only 289, despite having a diagnosis in the chart, 402 people with heart failure, only 289 actually had heart failure. So when you look at outcomes data from large groups, you really should try to dig down a little bit and see if they've adjudicated the outcomes they're trying to measure. A lot of times they don't, and it can be misleading. But the take-home point here is that older age in general, although young people like this case can get it, treated hypertension is often a risk factor. Diabetes, to Ole's point, can be a problem. And then you classify, and it kind of goes all over the map. They changed this HFrEF to HFprEF to HFmrEF. And if you can say that, you get a linguistic certificate, put it up next to your medical degree, and go from there. But that's the take-home point. And the handoff to cardiology, in my opinion, is very important for me for two reasons. One, I can't keep up with all these drugs, and they know, that just like we can manage antiretroviral therapy and they aren't comfortable, I can't manage the combinations and know what the latest data are from their meetings, and they can do that. But secondly, a lot of times you have to have them cathed. You got to make sure there's no underlying coronary disease. The treatment really does vary a lot, so I trust the cardiologist. But it's mostly to us to be more vigilant for looking for heart failure. That's the point. Okay, this question has already come up to me today from one of the attendees. What do I do with a patient who has an M184V on a cellular DNA assay? Let's look at the details. So a 65-year-old guy who's been diagnosed a long time ago is referred to you for evaluation coming from another clinic. The history is that he had multiple regimens in the old days that failed, and he ended up settling on dolutegravir 3-TC and abacavir and did pretty well. 14 months prior to his transfer, they simplified this to dolutegravir 3-TC, which a lot of us do, especially when somebody's on abacavir, because you're really not gaining a whole lot except for some cardiovascular risk. So a lot of us are downstepping that. That sounded reasonable. Had no historical resistance test available, but had a history, and no history of known virologic failure, although we might assume that he's had it. Now, this is the key point. During a routine visit, you're out of town, and a colleague,
Damn him.
yeah, orders a DNA genotype because they got nervous that there may be a 3-TC mutation, and lo and behold, it comes back with an M184V. What do? Stay the course, change isn't gonna be prudent, not gonna debt, like George Herbert Walker Bush? Go back to the abacavir, go to Bic TAF FTC, or fire your colleague for ordering that damn test. Go ahead and vote. That would be what Dr. Benimo would do.
Yeah.
Instead of flying off the handle.
5 bullets.
I hope you're happy. I hope you're happy now. I hope you're happy how you hurt your cause forever. I hope you think you're clever. I hope you're happy. I hope you're happy too.
Now streaming
I hope
on
you're
Peacock.
proud how you would grovel in submission to
Now,
feed your
what
own
has to happen now is I get on a podium and go
ambition.
way up into the top part of the stage and scream, ah, like that. Okay, 4% would fire the colleague. All right. Okay, most would be George Herbert Walker Bush. Thoughts, Roger? Why don't you weigh in here because you probably fire them first.
Yeah, if I don't get fired first. And so, yeah, I agree with the wisdom of the group. Now, the first thing is dolutegravir 3-TC in the context of an M184V is not dolutegravir monotherapy. M184V is an interesting mutation. It doesn't necessarily mean that 3-TC is not doing anything in that regimen. And so actually we're getting more and more confidence in using dolutegravir 3-TC in people with M184V. This is what we call archived. They did prove our DNA. And the latest data, I believe just like a couple of weeks ago, last week in CID, they excluded, however, people who had baseline archived M184V. But for the other ones, when they switched them to dolutegravir 3-TC, there was no difference in outcomes. So if you find out through lack of better things to do, you go testing for proviral DNA in somebody who's doing just fine with dolutegravir 3-TC, that means nothing.
Other comments, thoughts? Pretty much. So what's called the MUTA group, IAS-USA has a mutations group who publish those really nice charts that you can see what the resistance patterns are for genotypes. You can always also go to the Stanford database. But they have a paper in press that's looking at the value or lack thereof of DNA cellular resistance testing. And the bottom line is a fairly significant meh. meh, or it could be feh. If it's in Yiddish, it would be feh with a hand in an ulnar drift, feh. And so it's not really all that helpful. And in fact, it could be misleading. Why? Because of two big reasons. You can amplify virus that's incomplete. So it's a non-viable virus, so you get misled by a mutation that could have been there, but that virus isn't representative of what had been. Secondly, it's a little bit complicated, but sometimes the viruses are locked in the genotype by some cellular activity of something called ApoBec3C or 3B, and that you can't tell. So it's really, really hard to interpret, even if it may miss a mutation. So when you got something that's squishy like that, and you have, in this case, evidence that this guy's done fine, sort of don't enter the test in the first place. But if you really want to use it when you get somebody transferred in, you don't have much data, maybe, with big quotes in italics, it's helpful, but mostly it's going to be, in my opinion, misleading. So I think while we were excited about this 8 to 10 years ago when it first started to become available, I think we're learning that the clinical utility of this is meh. So how do I manage complications of an OI? And this, I think, is the last. This is a real, I usually don't use real cases. This is a real case. It's kind of interesting. There's a 35-year-old guy followed by you. 1 year ago, almost to the month and day, diagnosed with HIV, very advanced disease, like old school, PJP, MAC on lymph node biopsy. Viral load was 1 million. CD4 count was 7. Still see those type folks? Yeah, there you go. So got treated with Bic-Taf, FTC, Trim-Sulfa, Zithro with Ambutal, Rifabutin. Got better. In fact, eating, looking pretty darn good. We're all feeling good about ourselves. Then 6 weeks later, he develops, in essence, what's IRIS. And as you would picture it, and it's got steroids and improved. Then he got lost to follow-up. So everybody's demoralized, and especially me. So we try to call, we call the parents, and we don't know where he is. But finally returned, let's say about September, October, got him back on medicines, and he felt good again. Yay. But then about 6 to 8 weeks ago, he develops fever, anorexia, abdominal pain, constipation, viral load suppressed, taking his medicines. But his white count now is 21,000. CD4 count, as I mentioned. CT of the abdomen showed lymphadenopathy, necrosis, but the nodes are not bigger. They're not enlarged. LDH is normal, for those of you thinking lymphoma. And he got fine needle biopsies against my advice. I would rather have an excisional. It showed necrosis. It showed a lot of AFB, but they didn't culture it. So I don't know, So negative for malignancies, other cultures are sterile. So what do you think this is? I got some follow-up for you. Let's go ahead and vote.
After the war, I went back to New York. After the war, I went back to New York. I finished up my studies and I practiced law. I practiced law, bird work next door. Even though we started at the very same time, Alexander Hamilton
Into Act
began
1.
to climb. How to account for his rise to the top? Man,
Act
the man
2.
is non-stop.
Gentlemen of the jury, I'm curious, bear with me. Are you aware that we're making history? This is
Okay,
the first
you're right.
murder trial.
Okay, right, burden at work next door. Okay, so most think it's recurrent MAC, some think it's IRIS, bacterial superinfection. Any comments from the panel? Anybody want to weigh in and say what you think? It's a little bit of a hot mess.
I mean, if the cultures are sterile and it's about 6 months post reinitiation of ART, I think there's a high likelihood it's IRIS. I mean, the fact that there's AFB seen on the smear and culture negative, you don't know if those are alive or dead.
Yeah.
Probably in 2025, if you have access to it, you're going to do some molecular diagnostics to confirm that. That's also not going to tell you if it's alive or dead. And you're probably going to put them back on MAC treatment and give steroids.
I have this picture of a sort of histopath slide with a bunch of AFB and said, "Want it, dead or alive," but there it is. So this was a conundrum. I called a lot of people. I just show this to kind of say that, you know, there's still old school type stories showing up in our doorstep still, and we got to keep up with literature. But the classic things are kind of easy. These kind of curveball cases really, you know, at least they keep me up at night, or I think about it driving to and from work. And that's kind of, on one hand, the silver lining, kind of the fun of practicing medicine, but it's still harrowing, of course, for the patient and harrowing for us trying to figure it out. So he got readmitted last week we had put him on steroids. I talked to Irini Soretti, who's at NIH and has seen probably more IRIS than anyone. Lessons learned from that conversation: IRIS can come even 6 months later. A white count of 21,000 is not common, but has been reported, and the necrotic lymph node is pretty classic. So we're pretty happy with that. That was about 4 weeks ago. Went on steroids, tapered, and now he's back in the hospital. Our working thought is, and he's got new masses sort of in his neck, and his LDH is still kind of normal, but what I pushed for is an excisional lymph node biopsy that we can get cultures and all that. My bet is it's going to be IRIS, and we just didn't treat him long enough with steroids, and he may need something even more potent like an immune-based modulator. But this was an unusual case, so I thought I would end with that, just to kind of bring us back to the reality. So the conclusions are that art therapy should generally be started with an integrase strand transferred inhibitor-based regimen as close to the time of diagnosis as everyone knows. Weight gain is associated with initiation of almost any art. It's been associated with INSTIs and TAF, but really if you look at any art, your weight's gonna go up. And the GLP agonist, as Ole said, really the only intervention that works so far. And thank goodness for the diabetologist and the endocrinologist who got that to us. And if they can only figure out a way to make it less expensive, we'd all be happy. Chronic HBV co-infection with positive antigen is a relative contraindication for non-tenofovir-based regimens. We talked about bacterial vaginosis is an STI, finally nailed and proven. Mpox has limited treatment options, and if you ever have a case of Mpox, just send them to Columbia. Do not pass go. Unclear what to do for hepatitis delta, but it is kind of bad, and hopefully we'll have therapies in the long run. Heart failure is common, becoming more common in people with HIV, and the treatment's complex. Partner with the cardiologist. DNA cellular testing is generally not helpful, might be in certain situations, and tough cases are tough cases no matter where you live. So the panel was excellent. Thank you guys very much. Really complimentary ideas. Thank you all for paying attention. Okay, we have time for a few questions or comments. If you've got rotten tomatoes, throw them that way, and we'll go from there. Oh, okay, we have some questions coming in. What's the mechanism for true cabotegravir PrEP breakthrough? Rafa, you did the studies. Is it low drug levels, or is it just badness?
So no one knows the answer to this question. There are a couple of hypotheses about that, and that's if you look at the trough concentrations between the first 2 injections that are separated by 1 month, sometimes, and the PK is very variable. Nobody wants to talk about the fact that cabotegravir and cabotegravir rilpivirine, the PK is much more variable, both intrapersonally and interpersonally, than anybody wants to talk about. But there's sometimes some very low naders, even in plasma, between those first 2 injections. And cabotegravir partitions particularly poorly into rectal mucosa. It's about 10% of plasma levels. So if it's nadering in blood plasma, it's probably also nadering in rectal tissue. And so is that period of vulnerability an opportunity, if people are exposed, for it to be sort of a confluence of things that leads to acquisition that then is just difficult to diagnose later. So the question on the table then is, as someone is starting cabotegravir injections, should you overlap it with either a tenofovir-based PrEP regimen, or if they did the oral lead-in with cabotegravir, which very few people are doing these days because it's optional, overlap that some amount with the first set of injections. And if you look at the 2024 IAS-USA guidelines, it actually says to do that. That's the only guideline that says to do that. Full disclosure, we had something to do with those guidelines, so that you're getting a biased opinion. But it's an unknown. You'll notice, and Letitia's going to talk about this more, with lenacapavir also, there are some unexplained failures, even with, ostensibly good adherence. And, Letitia's going to talk a lot more about the context of what we know about lenacapavir breakthroughs. But, these injectable therapies, both for treatment and prevention, there's a price for that convenience, right? And that's even if you take them perfectly, there's a very low but real small rate of failure.
Ole, changing from TAF or INSTI to something else doesn't really help somebody lose weight, but is it reasonable to do just to keep them steady, or do they stay steady on their own? What is your experience with that?
So I think probably the HIV providers may have stronger opinions on that. I will say for steroids and these medications like olanzapine, the medications that cause weight gain, switching doesn't tend to lead to weight loss because it is really difficult to lose weight. So typically you see weight stabilization, and that's sort of the best you can hope for, which is why we often don't end up switching if they really need the medication. So I don't know the data specifically for the HIV medication.
Roger?
Yeah, like you said, many studies have failed to show good evidence of alteration of weight trajectories with switch. And the ACTG 5379 that you referred to is probably going to come out to say the same. The one thing that people haven't looked at carefully enough is that it depends. It matters a lot how long somebody had been on the regimen that you're switching from, because the weight gain is, I would like to call it, front-loaded. It happens in the first 6 months to 12 months. And any switch during that phase is probably more likely to alter the curve than switches after that phase, where you probably not. And the one inkling we got out of that is from the SALSA, was that SALSA or another dance study?
Possibly.
One of them. So essentially, they looked at people who switched before before finishing 1 year on TAF or after. And there's a big difference in weight trajectories when they switch before or after, regardless of what they switch to.
Right, so it doesn't
So it
really
doesn't matter what
yeah.
you switch to, but because the weight change goes up and then it plateaus, and when it's already plateaued, it's really hard to...
So on the same topic, there's a question here about an enlightened patient who comes in and says, I've read about these integrase inhibitors and TAF. I don't want to start on that. Give me something else. The patient doesn't have hepatitis B. What would be your regimen in that setting?
Well, right now, I think we have good reasons to not start people on protease inhibitors. That's clear. And unless we really have to, like Letitia mentioned, PrEP with integrase inhibitors. So if you don't want to use INSTIs at all, and you do not have, you don't want to use staph, the regimen that I would recommend doravirine TDF FTC, because I think it does work now. A lot of people in the US now think that giving somebody TDF is akin to malpractice because you're going to break the bone and kill the kidneys. But I beg to differ. I think that it may be a reasonable option.
Okay. Just to clarify, I didn't mean to take a shot at pharmaceutical rep, there's a question here about why did I say that about hepatitis delta? Because one of the companies has a drug that can be used. That's the one that's not available in the United States. Sometimes I've heard a rep coming in, hey, you're checking for hepatitis D. So I think that was my snarky remark. I apologize if it sounded offensive. Would any of you recommend, any of you do expedited partner therapy for BV? So, Letitia, would you, first case of BV, would you, but seriously, in a monogamous couple, would you just go ahead and treat the partner at the same time?
I would, I actually would. I think expedited partner therapy can be difficult depending on your local laws. Sometimes you actually have to have the name and date of birth of the partner in order to be able to prescribe. But yeah, I think that now that we have solid data supporting that, I would say many people suffer from BV and recurrent BV. So I think we should just cut the head off the snake and treat.
And a follow-up question for men, which often is, it often is asymptomatic, but what, men have symptomatic BV infection, urethritis, or skin lesions that you can think of? Not too much? No. Jason, no?
Rarely,
Just kind of silent?
Extremely rarely. Yeah.
Okay, so it's a silent partner of sorts, okay. Yeah. So the question, comment, isn't the BV study on a fairly small sample size?
There's been other studies that have shown potentially that you do have a signal in regards to this being an STI in partner studies. So I think this is just adding another layer to the evidence that's already supporting that this is an STI.
Right, right. Yeah, so can you clarify, maybe I'll go to Rafi, the comment about infection while somebody's on cabotegravir, knowing if it is or isn't a transmitted resistant virus?
So it's a great question, particularly around the issue of INSTI resistance. INSTI resistance being a transmitted phenomenon, still pretty rare. It is increasing globally, so it's something that needs to be monitored, but it's still a pretty rare event. In the particular context that we're talking about here of the 083 study, in almost all of the cases, we were able to, using low-level genotypic resistance testing, which was done at the University of Pittsburgh, we were able to demonstrate wild-type virus present before INSTI resistance emerged. So we do know that it was not transmitted resistance in those cases.
Yeah. And I'll just finish with it's a follow-on question asked independently about, pushing back a little bit on the IAS-USA guidelines that recommending right up front an integrase strand transfer inhibitor and sort of favoring TAF over TDF. What if providers want to do something different? Well, sure, you obviously can, and you should if you feel strongly that your option is going to, in a setting, going to be leading to weight gain that would be a problem. TDF as a rule has less weight gain, mostly because of a relative intolerance, and it just sort of is associated with less caloric intake. And so that's why a lot of times you see people going from TDF to TAF, you sometimes see weight gain, and it has to do with intake more than anything. But sure, I mean, there are options there. You could start with a non-nuke if you wanted to, but I will caution to say that all the studies show that there's weight gain with every regimen, every regimen. Non-nukes a little bit less than PIs, a little bit less than INSTIs, but all of them have a reasonable amount of weight gain. So it sounds like part of our counseling these days ought to include, hey, just want to give you a heads up that, and it probably has to do with the biology of HIV. You shut it down, and that suddenly all that energy that was used to fight the virus isn't being expended, and the patient gets healthier and gains appetite back, and it's a good thing overall, but it's something to kind of be aware of. Well, thank you all very much. I'll turn it back over to our chairs. I appreciate it.